Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. So far in the podcast, we've seen a more than slight predominance towards male guests and physicians featured weekly, and although I haven't heard any complaints, I know many of you are probably itching for more exposure to surgical disciplines. Well, if that's you, I'm sure you'll appreciate our featured guest on this episode. Dr Naadiyah Laher is a fellow in trauma surgery, currently working at Maxeke, Johannesburg Academic Hospital. A self-described Bara baby, she completed her junior years in and around Hani Baragwanath Academic Hospital before completing her 5 years of general surgery registrar time. As I mentioned, she is now a consultant surgeon and a fellow in trauma surgery and nearing the end of her training towards the speciality. I sat down with Dr. Naadiyah to ask her about her path in medicine, why she chose to specialize in trauma surgery, and how the realities of working in trauma compare to the often glamourised depictions we see on TV and in films. With this week marking the occasion of Women's Day in South Africa, we also diverted down a brief but frank discussion about the experiences of women working and learning in medicine. It's sure to provide much food for thought, and I hope you enjoy listening and learning in this week's episode. Without further ado, here is Dr. Naadiyah Laher. Welcome to the Dr. Coffee Podcast, Dr. Naadiyah Laher.
Yes.
It's good to have you on the show. Thank you so much for giving us some of your valuable time. With all of our guests, to set the stage and introduce you to our audience, I'd like to ask you about where you graduated medical school, and I believe that you did GEM, so tell me about that, and then when you did your internship and how that went.
Cool. So I did the scenic route to medicine, started off with a BSc. I'll be very, very honest, I did fail my first year BSc. The only subject I remember passing was maths and stats. And the other, physics, chem, bio, failed it by a very, very small margin. So anyway, my first year BSc was the best 2 years of my life for the first time. Got through the BSc, did a BSc honours in anatomy. And all the time trying to apply for medicine, applying everywhere, not really getting anywhere. And eventually in my honours year, I got into the GEM program. Because I'm older, that was a while back when they were still interviewing you before you got accepted.
Oh, wow.
Yeah. So,
was there an entrance exam?
We did that normal, consortium exam. It's not the exam they have now, so just that normal consortium exam that even the matriculants write. So we just did that, and you could have done, that time you could have done any degree to get in. So I remember having people that had done a BCom in my class.
Wow.
Had an interview which was very interesting, I might add.
How so? Do tell.
How so? So anyway, I had a part-time job as well while I was doing my BSc honours, and I was waiting to hear about medicine, waiting. And you know, as with everything in life, you always think there's a sign out there. Mm-hmm. The part-time job I had was cashier at a women's clothing store. So obviously there's women everywhere, and there will be a woman that decides to faint. So anyway, when you tell people you want to study medicine, they always think you are studying medicine. So this woman faints and they call me, and I'm like, I'm not a doctor, I'm not a medical student, but anyway, go and help.
Yes.
And this random person comes out of nowhere and she says, I'm a 5th year medical student, and pushes me out of the way, and she helps the security guard that fainted. And I looked at this girl and I'm like, just wait, one day I'm going to be there.
Did you feel really offended by it?
I did.
Yeah.
I was very offended by it, and unfortunately later that day I had gotten 2 letters from the university. One, a very big envelope, which one assumes is a
good news.
And then one small little envelope, which one thinks is bad news.
Which did you open first?
Good news, obviously.
Yeah.
So I go to the good news one, and it was my results from my honours year. So I'm like, okay, these are pretty good.
Yes.
Let's go for the small one. And the small one was a rejection letter.
From Wits, both were from Wits.
Yeah. For medicine. And I was shocked.
Oh, man.
And I'm like, okay, maybe I'm not going to be that 5th year. I was bleak. And then the very next day, on my way to work again, I get a phone call to say, you have an interview today at 12.
The next day?
The next day. So I'm like, am I dreaming? What's going on? Anyway, I asked the person that phones me, are you sure it's me? And they're like, yes. And because I spell my name very different to everyone else, I'm like, please spell my name. They spelled it correctly.
Wow.
I'm like, what's my student number? And they gave me everything. And I'm like, okay. Went for the interview. I tell you, it was the longest 30 minutes of my life to get to that interview.
How did you feel at the end of the interview? Did you feel like it had gone really well?
I'm a person that's, your parents always tell you when you're young not to back answer your elders. But I found myself kind of doing that in the interview because I got asked really stupid questions, to be honest. I got asked, how are you going to be a mother, woman, and a doctor? And
as part of your interview?
As part of my interview. And my response to that was, how are men fathers, husbands, and doctors? And as that words just came out my mouth, I was like, oh my God, I shouldn't have said that. That sounds very rude. And then I was asked, can you afford it? I was asked, at that time I was doing, I had finished my honours in anatomy, and obviously as a backup plan, you apply for masters and all of that. I could get an associate lecturer post, and it was like, I was asked, why do you want to be a student when you can be a lecturer and get paid, get a salary next year? And I asked, who would I be lecturing?
Did you feel like the questions were to try and discourage you, or were they genuinely trying to find out if you had thought about the way forward and different options?
I think it was to discourage. It just came across very negative. That was my worry. It's like, I don't know, you're trying to weed me out because why? Like, it's got nothing to do. Like, I had called people that had interviews before me, and all they were asked is why you want to do it. And I had that answer prepared. I had it prepared, but I never got asked it.
And deeper than, I want to help people.
Yes, much deeper than. And I never got asked it. Instead, I'm like, get all these curveballs. I told the person, they asked me, I'm like, who am I going to be lecturing? They're like, no, medical students. I'm like, I'm good enough to teach them, but not good enough to be one of them.
Wow.
This doesn't make sense to me.
Yeah.
So I was like, that's why I'm like, every time this words just come out my mouth, and I'm like, maybe you shouldn't have said that. Then at the end, with any interview, they ask you, do you have any questions? And I think a logical person would say no. But no, Naadiyah says, yes, I do have a question for you.
Do you remember what any of them were?
I asked the question, and they're like, sure, you can ask us anything. And I'm like, well, I got a rejection letter from you guys yesterday, and now an interview.
Yes.
What's going on?
Yes.
And all I got was, it's a mistake. And I'm like, you guys are
you
a tertiary educational institute. How do you make such a mistake?
Yeah.
Like, you printed out a whole letter, put it in an envelope, and sent it out.
Yes.
How do you make a mistake? Anyway, after that interview, clearly I was bleak, and I left. And then I'm walking out. My dad was there. I sat in the car with him, explaining to him that I think I messed up the interview, pretty bleak. And then I get a phone call to say, could you come back to my office? And I tell you how I remember this. It was the 15th of December, because the next day is a public holiday.
Yes.
And they're like, can you please come back to the office? And I'm like, okay, sure. And I walk in, and the lady tells me, please sit down. And being this stubborn person I am, I'm like, do I have to sit down? She's like, no, please sit down. I'm like, do I need to sit down? She's like, Naadiyah, just sit down. So I sit down on the edge of the chair, and she's like, we're pleased to tell you that after your interview, you did really well, and we're going to give you a post.
Oh, amazing.
I swear to you, I got up, I went behind the desk, and I hugged this lady. And
Oh,
I think
man.
she, like, the blood flow to her face just disappeared. And I was like, thank you. And I
Yes.
said to her, please can I have this in writing? Because tomorrow's a public holiday, and I will pay the money to secure the place, but I want this in writing.
Wow.
So then I got through the game program, and it was I think, very different being a GEMT in medicine because your peers are younger than you. You have a little bit more life experience. You're more matured, and you definitely know this is what you want. Where the other guys are still figuring it out.
What age? So after all that roller coaster, what age were you when you started GEMP, and what year would you have gone into? Because not everyone knows what GEMP is. We've got listeners in other medical schools and other locations. So GEMP is the Graduate Entry into Medicine program, and typically now you enter into third year medicine. Was it the same then?
Yes, it's the same. Your third year medicine, but you would start. When I did it, we started 6 weeks before the actual third years. Or we would call them the mainstream guys, and we were the GEMPs.
I know Wits hates the whole distinction between mainstream and GEMP, but it is helpful because there are people who have been prepared from the age of 18 who are going to be medical students.
And I mean, at that stage, they were accepting people that had done BCom, had no medical background. Now I know you need to have done some anatomy and physiology. It's very different now. Then you could have come without that.
Wow.
And
hence the 6 weeks.
Yes, in the 6 weeks before, we essentially had a 6 weeks crash course of second year medicine, where we did anatomy, physiology, mole med, I think, as well, in 6 weeks, you know.
Wow.
So, and then we started with the mainstream guys, and you could really see the difference. Because we had 6 weeks together as the graduates, we kind of grouped ourselves together, but with time we socialized with everyone. We got through it together. I think that's the one thing about medicine, is that you cannot do it by yourself. You need a community to get through it.
So having gone a slightly longer, you called it the scenic route through to medicine, do you think that those years were helpful in preparing you for medicine? Do you think you were better prepared to be a doctor having done that journey than somebody who's made the decision at 17 that this is what they want to do and they go straight in?
So I must say, I had lots of discussions with my peers at that stage, and some didn't actually know that they wanted to do medicine. Some did it because all their parents were doctors, you know, so they weren't really sure, but they were doing it and they were doing well, which kudos to them. The graduates, we knew this is what we wanted. We worked harder to get through it. I think it prepared me better in that I had life experience and that I knew this is what I wanted to do, you know, and I sucked up all the calls, did everything to get through it because this is what I wanted to do. And I think the guys that weren't too sure, because subsequent to that day, I've seen some of my colleagues that have left medicine and gone into the other parts of medicine in management, you know, which we also need. But one thing that medicine doesn't give you, we don't have that business mind. We're not educated in your 6 years or 4 years of medicine. There is no business courses or finance courses. We don't get that. And it's nice to have someone that has done their internship, so they do have the clinical experience and they do realize, you know what, I don't want to be a clinician, but I could help in other ways to make the system better. So it's nice to see that there are those people in the class too, as opposed to the whole lot of graduates that no, I've been through this, this is now what I want.
Do you think working in retail has made you a better people person and better doctor?
Patience. Women clothing and dealing with women, I think it taught you a lot of patience. Also how to deal with a lot of different personalities, because you get difficult people that want to return a thing when they worn it, you know, and you can clearly see that it's worn because it smells like washing powder or their perfume. And you learn how to deal with that, and you've extrapolate that to medicine. You get difficult patients, you get easy patients. Very good. And I think in both fields, you don't get those thank yous. Thank you from a patient, or thank you from when you help someone as a shop assistant. I don't know if you ever said thank you to the shop assistant. Wow. You know, now I've learned when before I was a shop assistant, I would take the clothes off the rack and be like, oh, just put it back wherever, because it's their job, you know. Correct. Now I don't. Now I'll fold it and put it back. So you learn some characteristics or qualities that would make you a better person, and you'll also be exposed to qualities that you don't want.
Very good. So I want to circle back again. You've now gotten into medical school, you've graduated from medical school. where did you do your internship?
Okay, so I'm a Bara baby. Bara was my only choice. I wanted it when you got exposed to it in medical school, that 1 day a week, I think in your 3rd and 4th years, and then more often in your clinical years. I wanted Bara. So I did my internship in Bara, and I think to me it was the best decision I've ever made. Really, really prepares you well. And you don't actually know how well it prepares you until you go and do your ComServe. So I did my community service at Beki Mlangeni Hospital.
Okay.
Back then it was called Jabulani Hospital, which is basically like, I think, about 15 kilometers from Bara. So not too far. It's not in the peripheries. It's not in the bushes somewhere. You know, it's pretty close to an academic institute. And I remember my one call, the very first call I did, it was putting in an ICD that somebody else didn't put in correctly, intubating an organophosphate, trying to extract a retained placenta all in one night. And it felt like I had done my 2 years of internship in that one call.
Wow.
And I was like, you know what? I made a good decision.
Yes, good
And
exposure, good training, good preparation.
You think when you're so used to as an intern having the reg to go to or a consultant to go to, and you're kind of safe that way. But when you do your community service, wherever you go, you generally by yourself, and you don't have that, can I call this person? And somehow, miraculously, that confidence comes and you do what needs to be done in that time and for the best for your patient.
I think the important underlying lesson from that for all junior doctors and medical students listening is get your hands dirty and get involved early on.
Most definitely. I think your internship is your training years, so you're allowed to make mistakes. You learn more from your mistakes and what you do when the things go right. Get confident in doing those procedures, intubating, CVPs, ICDs, because you don't know where you're going to end up. And if you're confident in that, also the other thing about internship, besides learning and trying to be a better doctor, it's about networking. You make friends in all the fields, because no matter where I was 11 kilometers away, but I had made friends with the surgical registrars, with everyone, and I could phone them and get advice from them. So make those friends, find someone that you can trust, that when you're a little bit stuck, it's just a phone call away, because they might not be able to come and help you, but they can give you advice over the phone.
Very good, very wise advice. Okay, so now you are a fellow in trauma surgery.
Yes.
Tell us a little bit about that. What is your scope? What are some of the things you see on a day-to-day? I'll let you take the lead in selling trauma surgery to us.
Most definitely. So, we first have to finish general surgery to get through to trauma surgery. And this is the beautiful thing about trauma surgery, is that it's very versatile and it's a variety of pathology that you see. So besides being your operative techniques, where 1 minute you're operating in the neck and then you're operating in the chest and then it's an abdomen or a femoral artery repair, it's quite varied. So it's not this mundane same thing over and over. You never know. So that's what I like about it, is that you never know what's coming, that constant adrenaline rush. The other thing is you're a little bit of a detective, hey, because we always say that stab wounds are a little bit more predictive as to where they go, but gunshot wounds, bullets do some weird things, whether it's in an abdomen or a chest. It ricochets over everything, so you need to put the puzzle pieces together, be a detective to see, is this where it go? There's a potential injury there, so that you don't miss things, And I think that's what keeps it interesting, is that you're constantly stimulated. You're constantly stimulated, and it's not the same things all the time. This is what I love the most about it. Your surgical skills, your skills to get confident in ICDs, CVPs, intubation. You do that for almost every patient, those unstable patients you come. And the most important thing I think about a trauma surgeon, and you'll see them, is that they're the most calmest person in the room.
Wow.
When blood is going around and alarms are beeping and everybody is panicked, they're the calm person. You take a breath and there's a protocol, there's a way to do things, HLS, and you do that and you will solve your problems. And I think for me that's something you can extrapolate to life. When everything feels like it's crumbling down, you take a breath and then you deal with it step by step.
Is that calmness all down to personality traits, or do you think it is something that comes with training? And if it's training, when do you develop that? I mean, as an intern, you can imagine freaking out. When did you develop that calmness?
So I think it's a little bit of both, right? It does come with training, because the more you see, the more you know, the more you are able to do. So it definitely does come with experience. But we teach you as a medical student, as an intern, we teach you approaches to stuff. So that's technically what trauma is. It's an approach to something. And because you know the approach, that's what makes you calm. You know I need to start. We're very simple trauma surgeons. We just know our alphabets, A, B, C, D, E. Just start at A and work your way. And such is life. There's always a starting point and there's an ending point. And if you just do that, that's what will enable you to remain calm.
Wow. Already I'm getting excited when you describe trauma surgery like that. I am a very excitable person, so I don't know that I could handle all of the pressure and stress as you're describing, especially with all that variety. What are some of the coping techniques that one needs to develop? Do you have any? I mean, after a busy day, do you feel completely wired? Or do you feel exhausted? How do you feel after treating such a variety of pathologies?
So I must say, as time went on, one would think that as a consultant you are less stressed, after a call. So we still do on-site calls. We're very involved because it is life or death situation. So we're never going to leave our registrars alone. We're always there, okay? And I do feel, I'm comparing it to my reg time and internship years. It might be a little bit that I'm a little bit older now, but I am more tired after a call. And I think it's more of a physical and mental tiredness, because remember, as a reg or as an intern, you always have someone to call. You're the consultant now, so you are the one they're calling. So I think that makes you feel a little bit more tired. But also, because you're always on site with your registrar, we're constantly teaching, whether it's in the resus area, whether it's when you're operating. So it's a physically demanding job, right? We're very busy. We have our quiet nights, and as with everything in medicine, you never say the Q words and never say it's going to be quiet. But we do have those nights, and you do have those busy nights where there's multiple patients you're operating on. And for me, yes, you are tired physically, because, we can't always do a 24-hour shift, and you can't always be on your feet for 24 hours. But you feel less tired, and you feel more relieved when, after you've operated on that patient and you continue your resus in ICU and you see them getting better.
Yes.
And then I know, what, I've accomplished what I needed to. And then I go home feeling, I made a difference. And then for some reason, you're no longer so tired.
So I imagine one of the hardest things to do is, because you care so passionately about your patients, one of the hardest things to do is to delegate the responsibility to people who you might feel would do less of a good job than you. Not to say they do a bad job, but because of your training, because of your experience, to hand something to an intern or a registrar who is still learning the ropes. What's it like to be on the other side and having to delegate that responsibility and trust somebody with someone's care?
In surgery, we do have a phrase that says, trust no one but yourself. And you never trust anyone, and you always do things yourself. But as I said before, in medicine, it's very much a team sport. You cannot do everything by yourself, so you have to delegate. So as much as I would like to do everything by myself so that I know it gets done properly, I need to have faith in my registrar, okay? Because they're also learning. And someone had to let go of the ropes too with me to enable me to learn. So I think of it that way, and that makes it more easier for me to delegate, to say, if I don't delegate this to the registrar and trust and have faith that they can do it, I am robbing them of a learning experience. And this is how I'm like, I need to give this to you so that you can learn from it, or I teach you from it. Whether it goes right or wrong, you will learn from it. And that's how it makes it a little bit easier. I must say, in the beginning, the first few months of being a consultant, it was very hard to let go, because you were in that registrar, I must do this, I must do this. It was very hard in the beginning. But then when you see that you're robbing someone else of another learning opportunity by not delegating, you then realize there's a bigger picture.
Thank you so much for that, because what I'd like our audience to hear and take note of is that for us, if we're chasing procedures and we get to do things, we need to recognize that that is a privilege to do those things under supervision, and not to shrink back when somebody says, hey, come do this, because they are extending themselves, extending the opportunity to someone for their training. So it's so good to hear a consultant say, I want to do everything, but I recognize that I need to help other people to learn and grow. So that's wonderful.
No, most definitely, because best time to learn is when there's someone there that can correct your mistakes. You don't want to be learning this by yourself.
Yes, okay. As you described, as an MO on ComServe, like having to do so much.
Because it takes time. You're not going to get it on the first time. You need time to build your own confidence in it, and you have to have that opportunity, and someone has to give it to you.
Wonderful. Dr. Laher, you mentioned a path to trauma surgery where you said you had to do general surgery first. Was that a 4-year reg post in general surge?
I wish. 5 years.
5 years. So 5 years. When did you write your primaries?
Okay. So I did my ComServe, and because I'm a Bara baby, I did 6 months of MO time in surgery at Bara. At that time, there wasn't many people applying for surgery. Surgery has become very common right now because we've gotten a lot of people applying, which is amazing. Like, it's very nice to see that people are more keen. Everyone is deterred from it because of a lifestyle choice, but it is what you make of it. So after 6 months of MO time, I got a reg post. To apply for a registrar post, you must have had primaries, so you must write primaries. It is getting much more competitive. I was the registrar representative while I was a reg, so I had set in on interviews for future registrars, and because it's so competitive, people are now applying with intermediate exams.
Oh, wow.
Okay, so that you obviously look better on your CV as opposed to someone that doesn't. So it
and
is...
And more MO time, or also 6 months?
Some have more, some have less, some have more exams, some has more research. So you can see all universities are pushing research. So the bare minimum that you should have is to apply is your primaries. You must have an ATLS course, very, very, very good course to attend, and some sort of research. That's the bare minimum. And I can tell you there's people coming with PhDs, multiple publications, with intermediate exams. So you have to sell yourself.
And typically, how many posts would there be on one intake, and how many people would be applying for those posts?
So it's very dependent on how many people have written the exam, right? So there's 2 final exams. There's 2 semesters. In Feb, March is the one, and July, August is the second one. Depends how many people write, how much reg time they have left. That's how posts open. Okay, so it's very controlled. Very last, I think I was the reg rep until 2020. So the last one I attended was about 5 posts and 30 people interviewing. Okay. So it's quite competitive. Yeah. Okay. MO time, cutting time, it was varied amongst some people 6 months, some people 2 years. Very varied. So again, you must have the bare minimum, but the more added you have, again, puts you higher up on the list. So with us, you do your primary, that's just to get in. You have to, at the VIT circuit, the intermediate exam should be done during your junior time. So our surgical registrar time is separated between junior and senior time. So junior time is 2 years, and then senior time. What I like about our program is that we get re-interviewed to be senior registrars.
Wow.
You don't just become a senior registrar. Yeah. So again, there's another qualification process. So you must have done 2 years of your reg time, you must have had your protocol for your MEd approved, and you must have passed your intermediate exams. You are then interviewed by all the big profs. Very, very, very nerve-wracking interview to go in a room full of the big profs. And you get interviewed, and if everybody's happy, you then get promoted to the senior post. Then you become a senior reg. And then obviously you then have to plan when you write your finals, which is the big one.
So you said that even though it's a very nerve-wracking exam in front of all the profs, You said that you like it. So why do you like that bridge between junior and senior?
I think there's a big difference between being a junior registrar and a senior registrar. You take a lot more responsibility as a senior registrar, and at the end of the day, you're in a unit, right? And as the consultants run the unit, you should emulate that, because at the end of the day, when you pass that exam, you're going to be a consultant. So if you cannot run a unit and you cannot have the ability to delegate and do what you need to do and delegate and trust other people, then are you really ready to be a consultant?
Wow.
You see, so that's, I think, and a lot of interviews, I think, it's much more easier to sell yourself when you're talking than on paper. Some of us cannot sell ourselves very well on paper, but we sell ourselves when we talk. And there's a thin line in surgery between confidence and arrogance, right? And you need to find that line. To become that senior registrar, also, you need to know what I can manage by myself when I do need to call someone. You need to know the difference. And that all comes with experience, with maturity. I remembered one of my junior rotations was in Klerksdorp, very far from here. And we did this in appendix for 4-quadrant contamination, washed him out, did his appendectomy. He stayed for about, I think, a week or so in hospital and went home. And then I came back to Bara and did a registrar rotation there and had the exact same patient, and he went for multiple relooks. And I thought,
same type of patient or the same guy?
Same type of patient.
Yeah.
A perfed appendix, 4-quadrant contamination. He had planned relooks for washout again, had multiple more relooks for washout. And I thought to myself, how did I not plan a relook for that patient in Klerksdorp? Now, ignorance is bliss. When you don't know about something, you never anticipate it, you never plan for it. Major difference between a junior registrar and a senior registrar and a consultant. Yes. You know, it's about, as you get more experience, you anticipate complications and you plan ahead. But when you're junior, you can rattle off the complications because you've studied it, but you don't anticipate and you don't plan for it.
Very good. So my next question is, what does a typical work week look like for you? How much of your time is spent in theatre? How much of it is on the floor in the pit? How much of it is in the wards?
Okay, so we have an elective list on Mondays. I do the elective list every Monday. We do pretty cool cases, so at least an 8 to 4 day there. Then every other day is we do consultant ward rounds. So we have our regis round from about 7. We start rounding at 8, and it's a teaching. Every ward round in our unit is a teaching ward round. So our ward rounds do take long, but they are teaching, and it's bedside teaching. And I'm not sure about you, but I think even as an intern, I learned more at the bedside than what I learned studying in my room, you know. Then afterwards we have, like, for example, Tuesdays our rounds would start later because we have M&M on a Tuesday. On a Wednesday we have an academic day, so we have a grand ward round. That's at around about 11 o'clock. Okay. On a Thursday we have teaching again for our registrars, where they prepare a presentation. We have a journal club as well. And then Fridays is our clinic days. So I mean, it's you have sometimes early days, sometimes late days. Trauma is unpredictable. When you throw in calls there, then that obviously changes things, because then you're there for the whole 24 hours. You have your early days, you have your late days, but reasonably chilled.
And then, sorry, I forgot to talk about your trauma surgery specific subspec training. We spoke about the 5 years of being a surgical reg. Is there any way that one can go just into trauma surgery, or does everyone have to do general surgery?
No, you have to do general surgery first. So trauma surgery is a fellowship. So you have to be a general surgeon, and then it's the same process. You have to apply for it, you get interviewed for it, and then you do a trauma fellowship. So I'm currently in my trauma fellowship. It is 2 years. Okay, and after 2 years, again, there's a MCQ exam and an oral. And it's a trauma and critical care fellowship. So that's how we are exposed to ICU training. I mean, with surgical reg time, your intermediate exams already got some critical care in there. So we're exposed throughout. And it's to instill the principles of pre-operative management, intraoperative management, and post-operative management. So cheers is not a long time compared to 5 years of gen surg.
I'm sure it just flies by.
Yeah, it definitely does. But, you know, I think it's even quicker when you're doing what you love.
Yes.
I was just getting through that 5-year road to get to trauma surgery.
So when did the bug bite that you decided trauma surgery was what you wanted to do?
This is so strange. I remember in medical school you had to do electives, right? And I did an elective in peds, I think it was 3rd or 4th year, because I thought I wanted to do peds. Did not like it. Then I said I wanted to do medicine. Did my elective in medicine, did not like it. And I then spent some time in trauma as a student, and I'm like, no, this is really what I want to do. And again, it goes back to the calmness. I was an intern in anesthetics at Bara, and the prof that time was doing a stab heart.
Wow.
And myself and 2 other anesthetists were pushing blood in this patient, and the prof was the calmest person in the room, just suturing a beating heart. So calm. And I looked at this man and I'm like, this is what I want to be. I want to be that person. Because when there's one person calm in the room, that calmness just goes to everybody else. And it makes a life-threatening situation much more manageable for everyone else. It's a bit senseless to have everyone freaking out and throwing tantrums and raising voices, because then nothing really, you have no closed loop communication, nothing is really actually communicated because everyone is so anxious and stressed out. But when I seen that, how his calmness had translated to everybody else in that theater that night, it solidified that trauma surgery was what I wanted to be. And I emulate every time I'm in theater with an unstable patient that I am like that.
So if somebody was listening to this podcast and they wanted to come up with a decision algorithm that would take them down to surgery, what would some of the features of that person be? What kind of personality? What kind of interests do they need? And maybe we can flip it and say, who should not do trauma surgery? What kind of doctor should not set foot in the OR for trauma surgery?
I wonder if you can actually say who should not, because you'll be surprised of what you're capable of when you put into a situation. And you never know until you actually test it in such a situation. Because I've seen a lot of people when I was in medical school that all wanted to do surgery at the time that I wanted to be a physician, and they all wanted to do surgery. And I was that person that said, oh no, you're crazy to do surgery. There's no life there. And I flipped, I became the surgeon and they didn't become the surgeons, So I don't think you can really say there's no one really capable of doing it. I must say that you must be really resilient. Surgical reg time is tough.
You mentioned how they interviewed you for medicine and said, how would you handle being a wife and mother? And don't you want to have a family one day? And I loved your answer when you said, well, how does a man do it? Because it's not just one family or one member's role to parent children or to have children. So now, being a woman in medicine, you mentioned there's a resurgence of women in surgery, and that's fantastic to see. As a woman in medicine, what do you think is the way forward for women in medicine? And how would you answer that question if you were to go back and say to Naadiyah in the process of getting into medicine? How would you change your answer, if at all?
So I don't think I would change it much. I might have more evidence for it, because I had read a recent article with evidence-based medicine that theatre with a female surgeon has better outcomes. So I'm going for the evidence here. I do think what is nice, and this is what I had during my reg time, I was exposed to females that found other females as their competition.
Okay.
And would not help you. They would actually be mean to you because they felt like they were competing with you.
Wow.
And I had a female role model, if I may mention her name, is Dr. Vicky Jennings. She has been my role model since an intern. And she saw the potential in me that I might not have seen at that time. She saw it and she nurtured it. And I must say a lot of where I am is because of her. And I think with having more females, we're becoming less competitive with each other, because it's not, we only 2 females in the circuit, we need to outdo each other so that we can show I'm the better one.
Wow.
It's no longer about that. It's like a 50-50%. So I think there's more camaraderie, there's more support. It's more like We need each other to get through this.
I find that so interesting, that having a minority of women in medicine made you more, if I can say, more backbitey at each other, more competitive and less personable, because of that. Oh, I'm a woman in medicine and I'm a minority and all of it. Like, you felt that pressure, but now because there are more women in medicine, you feel, can I say, more free to pursue the career.
More free and more supported, because you don't need to. You're not competing with each other. It's more like we're competing with the guys now.
That's excellent.
No, but I do think it is about support, whether it's females supporting each other or males and females supporting each other. You definitely need it in any reg time, any time in your career, whether it's internship or concept. You definitely need it. It's a team sport, because competing against each other, at the end of the day, affects your mental health. And if your mental health is affected, you then have poor outcomes for your patients, because you are now distracted. So I do think that having that support with each other, where we're not constantly competing to say, you know what, it's almost like, I think having the minority of females at that time, it's as if they felt threatened that if something went wrong, that their post will be taken away. And that's why they competed so aggressively with each other. That's what I actually saw, until I was exposed to a supportive female. And I must say, anyone you come across, whatever their character traits are, use it to your advantage. See what character traits you want to keep for yourself, what type of registrar you want to be, what type of consultant you want to be, and see also those traits of people that you don't want. And you need to try really hard to not turn out to be like the people you don't want to be. Emulate the good ones, because it gets in this stressful work environment with all these pressures. I know with COVID, the burnout of doctors have become more popular, and people are talking about it more than what they used to. It's very easy to get through that way where you have no empathy because you're burnt out and you're tired and you lose that bit of resilience. Like, we need some of that resilience to keep us going and to be good role models. But don't disregard the bad role models, because they tell you who you don't want to be and will be constant reminders that you don't want to be like that.
This week in South Africa, we celebrated Women's Day, and it's a great time to talk about issues affecting women, not only those in medicine, but at society at large. For women in medicine, I think it's important that we raise issues such as sexism and such as this competition that you mentioned between ladies. I think sometimes medicine can have bad cultures and good cultures. Do you think that the culture that is within surgery at the moment is healthy? Is it heading in a good direction? And if not, what can we do to change it? Is it something that needs to come from the top down? Is it dependent on the juniors coming in? Because the expression is what a culture is. A culture grows. Yeah. And it's so easy to come into a department and think, well, this is the way it is. This is who I need to be as a surgeon. And I'm not going to say anything because I don't want to lose my reg post.
I think with the equal numbers, 50% of females and males, we are headed in the right direction. We have lots of support programs for females to making it a little bit easier on you if you want to have a family, in surgery. There are ways to do it. There's lots of opportunities of how you can do that. We've had many females that have had kids, have been pregnant, and they got through reg time. So I do think because we're more there, people are becoming more aware of what females need to get through reg time. It's a little bit different to what males need, Not to saying men don't need to be there for their kids, but a little bit different when you're pregnant.
Yeah, let's be honest. Men are not carrying a human baby for 9 months.
So I think, before you couldn't really fault the people back in the day of how they treated women. They didn't know. Because there weren't very many women there.
Men are trash.
Know.
That's the reality. We had this discussion with Dr. Jared Zamperini, obstetric medicine, that if men were to carry babies, there would have been Cain and Abel and no more.
Definitely, they won't stand the pain. They have the lowest threshold for pain. But I think now that we are there, people are becoming more aware of our needs and what we do need. We don't want to be treated special. We don't want any special things. We just want to be comfortable and have what we need to exactly what they asked me in my interview, so that I can be the mother, the wife, and the doctor. Let's say surgeon.
Yeah. Wonderful. So what message would you like to pass on to junior doctors? Maybe some life advice, or with the benefit of hindsight and experience, think back to when you were in your clinical years in medicine or a junior intern. What would you have said to yourself just to pass on?
Nothing is impossible.
Great.
Don't let anyone tell you, because I was
Love
told
that.
you're never going to get into medicine. You shouldn't do surgery. I think take those no's as that's your challenge. That's the competition. That's what you compete against. You compete against yourself. You compete against those no's.
Wonderful. And is there any resource that somebody can get a hold of that will help them to be a better trauma surgeon one day? If somebody has a burning passion to be a trauma surgeon, what would help them?
HLS is the beginning phase for trauma. Like doing that course is amazing. Most trauma surgeons are HLS instructors, so you will find us there. You'll see our passion. The trauma books are quite a lot. There's a DSTC book. There's a trauma. That's the name of the textbook. There's so many books available, like literally the best way. So yes, there's lots of reading to do, but just come and spend some time in our unit and you'll see.
That's my next question, is that if somebody wanted to do an elective in trauma or they wanted to shadow you for some kind of work experience, how would people be able to take part in that? How would they reach the departments to?
They're more than welcome to at any time. At Simja, our trauma office is in 377. Just there, they can come there and they can arrange any time to spend some time with us.
Wonderful.
We are more than welcoming.
Love that. So what does the future hold for trauma surgery? If I was to say in the next 10 years, where do you see trauma surgery heading? Are there new fields of research? Are there new breakthroughs in treatment?
There's lots of... we're heading towards a non-operative management kind of era. There's lots of stuff we are seeing that we can manage non-operatively. And this is with your angioembolization now becoming available, much better places to observe patients. So there is a move towards non-operative management for some stuff. But there's also still a lot of surgical stuff that, as South African trauma surgeons, we have the most experience with your penetrating trauma, as opposed to globally where blunt trauma is more predominant there. So, I mean,
do we have statistics on hand of like how many times more we see stabs? And
so I can just tell you our statistics are, it's not something to be proud of, but
Sure.
we have the third highest rate of interpersonal violence. So this is attacking each other. The third highest rate.
South Africa or
South Africa.
South
Wow.
Africa
has the third highest rate of interpersonal violence.
Who's ahead of us?
I know Brazil is quite high up there
Really?
as well. So I mean, we have the third highest. Some cities in America, like Chicago, has a high gun rate, but remember their gun laws are much different to ours. From just purely on, I can just give you some stats. For example, I did my MEd, just auditing penetrating neck injuries at Bara over a 5-year period. That was my MEd. And I found 855 penetrating neck injuries over 5 years. And when I was doing my literature review, I remember reading a study in the UK. In over 10 years, they found 100 patients.
Wow.
So that's just to put in a little bit of perspective that our numbers are really big. Not to be proud of, but
Yes.
It has given us a lot of experience. We always have foreign surgeons coming from anywhere, Sweden, Finland, Germany, Spain, coming to our trauma units to come and learn how we do things. And I mean, I'm sure if you were in a war, you maybe want a South African trauma surgeon next to you.
Well, I mean, sometimes the pit at Bara is like a war zone.
Almost every Saturday, yeah. So, I mean, there is a move to, I mean, the more you see, the more you know, and it's just about getting our evidence out there. So that's my little baby that I want, is to focus on the research to get our numbers out there so we can show that we actually do know what we're talking about.
Wonderful. Now, Dr. Laher, when people meet you and they hear, oh, you're a doctor, and they have a preconceived idea in their mind perhaps of what a doctor's like, and then when you tell them you're a trauma surgeon, what kind of response do you get? Because sometimes it's glamourised by TV programs like ER and Grey's Anatomy, that trauma surgeons like the pinnacle of achievement in medicine. Is that how people respond to you?
So number one, not yet a trauma surgeon. I need to get through that exam first. But because I am petite, I think is a nice way to put it, people obviously don't think I'm a surgeon, number one. So it's more like disbelief because you're a petite woman.
Sure.
Disbelief, that's all. It's not about, oh, glamorous, oh, you're a trauma surgeon, you can do anything. It's about, oh, you're a female and you, some people use the word tiny, which I hate. It's petite. And it's like, oh my God, how can you be a surgeon?
Wow, that's actually so negative.
It is.
Do you ever call them out on that? Because that's a terrible attitude to have.
It is a terrible attitude to have. I'm like, you know what? I don't need to prove anything. If you have your preconceived ideas, it's okay. But I'm sure if you get stabbed or something, you'd want to come to me.
I mean, you don't wish that on anyone. But
I do not wish it on anyone.
You'd make them eat humble pie.
You know?
Hi, it's me, the petite doctor. You didn't think
it's the petite one. Yeah, no. I don't think, I must say, those TV programs, they always have the whitest lab coats and the bluest of blue scrubs. This is why we prefer dark colors, so that you guys don't see the blood on our scrubs.
So would you say that what you see on TV is not at all an accurate reflection?
Definitely not. I try to avoid watching them because when I watch them, I get a little irritated as to, that's not what you do. But yeah, it's a little bit glamorized. It's not glamorous, it's hard work.
Yeah.
It's very hard work. It's very stressful. It's life and death,
yes.
You know, most of the time with us.
How do you find balance? I mean, it must be so difficult to have balance and maintain your studies, because you said you're preparing for an exam, but at the same time you're supervising registrars, you're doing calls still, 24-hour calls. How do you find balance?
You have to make time. I learned this. I did not do it as a reg.
What did you cut out? What do you say no to?
I did not do this as a reg, and I learned now. So after I finished my reg time, I was unemployed for about a month while I was waiting for a post. And in that month, I didn't actually know who I was. Because if someone asked, who's Naadiyah? I'd be like, I'm a surgical registrar. I didn't know what I liked, what I didn't like, because I spent all my time being a surgical registrar, you know, and you need to make the time. And you asked me, what did I say no to? And this is the problem. You need to learn to say no. Okay? So, but also be realistic, because you have to find the balance of saying no when it comes to you want to get more training and learn more, but also know, like, you know what? I am tired. My body needs to rest. I am taking today off. I take a detour and I go visit my brother and his 3 kids. And then I realized after a few hours with those 3 kids that I'd rather do a 24-hour trauma call than deal with children, because they are more tiring than a 24-hour trauma call. They never ever stop. And I think you find those things that just rejuvenate you, whether it's spending time with kids, spending time with a loved one or your family, or just Netflixing and chill. You do what you need to do to get back to what you need to be to function. But just learn a bit to say no.
I love that. And on that note, I think we're going to come to the end. But I just want to thank you so much for giving us an insight into your journey. It's so wonderful to see you flourishing in your dream and in your passion. And it was great to get some of that on the podcast. We look forward to seeing you as a consultant on the rounds. And thank you once again for appearing on the Dr. Coffee podcast.
It's my pleasure. Thank you.
I hope you enjoyed this week's episode as much as I did. If you know of a consultant or senior registrar in a specialty that you would like featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram and YouTube with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you. The Dr. Coffee podcast is brand new, with freshly brewed new episodes each week on Apple Podcasts and Spotify. Please consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy. You can also help by posting a picture of your favorite warming beverage on Instagram with the hashtag #HowsItBrew, that's brew with an EW at the end, and mentioning @DrCoffeeZA. We'll repost every mention to our story. Thank you so much for your support.